All right, good evening, everybody. Welcome to part two of our three-part vaccine speaker series with Carnegie Science Center. My name is Brad Peroni, and I will moderate and help this conversation flow tonight. I am honored to be joined by some amazing doctors and researchers. I would like to note here at the outset that one of our panelists, Dr. Tulia Bruno, had to cancel at the last moment for some personal reasons. So our panel will be three experts this evening. And to get things started, I would like to introduce the Deputy Director of Carnegie Science Center here in Pittsburgh, Kim Amy.
Thank you, Brad. Thank you to our esteemed panelists for joining us this evening, and a very special thank you to all of you watching from home. At Carnegie Science Center, we aspire to serve as a trusted voice of science for the general public and as a town square for community dialogue on science and its social implications. As such, we feel it is not just our mission, but our duty to convene conversations like the one we're having this evening. I don't need to tell you that this past year has brought unprecedented challenges to all facets of life. Even as the global pandemic continues, increasing vaccination rates promise a return to normal. We're seeing it more and more as we're out and about in the places where restrictions are lifting. But that return to normal depends on enough people being vaccinated to stop the spread of COVID-19. During the pandemic, we saw the process of science playing out in a very public way. Early confusion and disagreement between experts about the virus, the accelerated pace of new vaccine technologies, and rapidly changing recommendations left many people feeling exhausted and confused. And this confusion, coupled with a divided social and political climate, contributes to some Americans being hesitant to receive a vaccine. The US Census Bureau offers a household vaccination tracker that shows national and state-by-state percentages of population hesitant to receive a COVID vaccine. Data from its most recent collection cycle ending May 24th points to 11.4% of adults ages 18 and over who say they will definitely or probably not plan to be vaccinated. Another 5.7% are unsure. That hesitancy rate is slightly higher here in Pennsylvania. Concern about safety and side effects, mistrust of vaccines or the government, and uncertainty about whether an individual needs the vaccine were chief concerns cited in the survey. Tonight's panelists are experts in their respective fields and bring years of clinical and research experience to this conversation. I know the discussion tonight will shed light on many aspects of the impact of the COVID-19 pandemic, community health, vaccine development, health equity, just to name a few. If you are hesitant about receiving the vaccine, I hope our panelists can help to ease some of your concerns and provide information that you can trust. If you have a friend or loved one who is hesitant, please encourage them to join us for this conversation or for the final installment of this series on July 1st. And so it is with my most sincere thanks to our guests tonight. I'd like to turn this back over to Brad to get the conversation started. Thank you.
Thank you very much, Kim, for that introduction. And before we introduce our speakers for this evening, our panelists for this evening, I would like to make sure that everyone knows that this panel discussion is being recorded and will be available on Carnegie Science Center's YouTube channel in the next few days. So please feel free to share the video of tonight's discussion with anyone who you feel may benefit from hearing it. For tonight's discussion, we're going to start by giving each of our panelists a bit of time to offer some initial remarks about their work as it relates to COVID-19, and then we will move into questions that were submitted in advance by those of you out there in the audience. Hopefully this discussion will provide a lot of great information and shed some light on many of the questions that people still have about the COVID-19 vaccines. The first panelist I'd like to introduce this evening is Dr. Amesh Adalja, a senior scholar at Johns Hopkins Bloomberg School of Public Health, Center for Health Security.
Hi, thank you. Thank you for the invitation to speak. Thank you for attending. Thank you for this whole opportunity. So what I'm going to do in about 5 minutes is kind of give you an introduction to who I am and the work that I do. So my name is Amesh Adalja, and although I'm a senior scholar at the Johns Hopkins Center for Health Security, I'm based in Pittsburgh, and I am an infectious disease, critical care, and emergency medicine physician, and I've been taking care of patients in this area throughout the pandemic. But what I do in terms of the work at the Center for Health Security is I specialize in understanding emerging infectious diseases, pandemic preparedness, the intersections of infectious disease and national security. And what I try to do and what the center does is bridge the gap between science and policy and try to make the country and indeed the world more resilient to the threat from infectious diseases. So a lot of that involves kind of scanning what's going on out there in the field. What emerging infectious diseases may be occurring? What are their implications for spread? How do we prepare for them? How do we mitigate their negative consequences? Do we have an apparatus to make drugs, diagnostics, vaccines? And we really try a lot to interface with policymakers in Washington in order to get them to take this threat seriously. So throughout this pandemic, I've been doing a lot of that, giving congressional briefings, writing, speaking to the public, speaking to the press, almost constantly since January of 2020. And one of the things I want to emphasize is that the way that this pandemic occurred wasn't something that was preordained. This happened because of mistakes that were made early on in January, February, and March. And to many people, COVID-19 seems surprising to them. But a couple of years ago, I gave a lecture at the Carnegie Science Center in person where I talked about the characteristics of pandemic pathogens. And if you look at COVID-19, I think it's something that we should have very early on knew was not going to be containable, because this is a respiratory virus that spreads efficiently from person to person, has people who are contagious when they have no symptoms or don't realize they have symptoms, has an animal host that we don't know what it is. We know it comes from bats. We don't know where else it is. So this isn't something that was going to go away or disappear. It was going to transmit much differently than, for example, SARS or MERS, which happened in the past. And I think that really should have conditioned a response. So what we've been trying to do is not eradicate this disease or eliminate COVID-19. That's not going to happen. Our goal has really been to try and minimize its impact in terms of serious illness, hospitalizations, and deaths. And the best tool that we have for that is the vaccine. That's what the vaccines are designed to do. And walking around in a hospital now in June of 2021 is very different than what it was in January of 2021. And the major difference there is our high-risk population is so heavily vaccinated that we've sort of tamed the ability of the virus to crush hospitals. So that's what the vaccine offers. It offers a way to really pull you back to pre-pandemic life or post-pandemic life, and is a personal value to the person getting vaccinated. And I think it's really important because we have to be much more resilient to infectious disease threats, because this is not the only infectious disease threat we're going to face. Probably even in the next 5 years, there's going to be another infectious disease emergency, and we have to get this right. And I think vaccine hesitancy is something that I think is very, very important, because it could be something that compromises our ability to respond to the next infectious disease emergency. The other point to make is that we have to invest in public health infrastructure. And I've been trying to advocate for that for some time, because when it comes to an infectious disease emergency, public health infrastructure is what's going to guide our response. They are going to be the soldiers that actually execute the public health response. And we can't have public health be chronically undervalued, underfunded decade after decade, and expect to be able to handle an infectious disease emergency. We have an opportunity now to set this right. I think that we have to think of this pandemic as a failure of many different government agencies from the federal, the state, and local level. And we have to now advocate to never let this happen again. that public health needs to be prioritized. It needs to be removed from cycles of panic and neglect or boom and bust cycles and be sustainably funded. So those are some of the things that I work on with at the Center for Health Security. What I'm actively doing, again, I'm taking care of patients throughout this whole pandemic here in the Pittsburgh area. So that was very eye-opening to me to be able to move from the clinical situation in a hospital to the policy, to the Washington angle of this, to the press, talking to the general public. So I think I bring a kind of unique experience because I see all of that. I'm happy to take your questions. And again, thank you for the opportunity to speak to you.
Thank you very much, Dr. Adalja. I look forward to hearing more about what you have to say about upcoming possibilities for infectious diseases. Up next, we have Dr. Paul Dupre, and Dr. Paul Dupre is the director of the University of Pittsburgh Center for Vaccine Research. Dr. Dupre.
So thank you so much for the invitation. I'm really glad to be here and speak about why vaccines matter when viruses emerge. Here in Pittsburgh, we have a long history in vaccine development. In fact, the chair that I hold in the University of Pittsburgh is the Jonas Salk Endowed Chair for Vaccine Research, a name which is synonymous not just in Pittsburgh, not just in Pennsylvania, not just in the United States, but across the world with vaccine development. And Salk's legacy runs through the veins of this city. Just like the rivers run through our valleys, vaccines and Pittsburgh go hand in hand together. And that's why the Center for Vaccine Research exists, because of this tremendous history in vaccine research, in infection biology, right across the University of Pittsburgh and elsewhere in the city. What's special about the Center for Vaccine Research is we have a biocontainment laboratory. And whenever viruses emerge from typically animal hosts, they're out in the environment. And what scientists, virologists like myself do is we bring the viruses from the outside inside. We use biocontainment laboratories, which are highly regulated, well maintained, and have a wonderful staff of highly trained individuals to work safely with these viruses. And remember that whenever SARS-CoV-2 emerged 2020, we really didn't know very much about that virus in particular. We knew about coronaviruses, but not about that virus in particular. And we worked with them in a biocontainment laboratory class 3. So there are 4 different classes of viruses that we can work with. One is just the typical agents that would be on your hands. They don't cause significant human disease. Class 2 viruses are viruses for which we have vaccines, like measles and mumps. You would be familiar and maybe even vaccinated with those. Class 3 viruses are viruses like highly pathogenic avian influenza, bird flu, and SARS coronavirus 2 is also a class 3 virus. And because we have those capabilities in Pittsburgh, we were able to get the virus directly from the Center for Disease and Control in Atlanta in the early stages of the pandemic. February 2020, that virus arrived in Pittsburgh. And we've been working with it in the Center for Vaccine Research ever since. Just to finish off the 4 categories, the class 4 viruses are Ebola. I'm sure you're aware of that. And many of these other viruses for which we don't have vaccines that are able to be administered to protect people. So what we know about vaccines is, number 1, they're really well understood and well researched in Pittsburgh. Number 2, they work. But what we also know about vaccines is people have many questions. People understand much more about vaccines now than what they did this time a year and a half ago. And people have many questions about vaccine development, vaccine testing, vaccine safety, all of those different questions that drive people to be somewhat hesitant. Not everyone, but some people, as you've heard in our opening remarks. And what's important to say at the beginning of this conversation, and it should be a conversation, there is nothing wrong with asking questions about how vaccines work, how they were developed, how they were tested, how efficient they are at protecting the disease, what they do. None of those questions are wrong. In fact, that's how we learn. So from my perspective, it's just wonderful to be on this panel this evening in Pittsburgh, speaking to people in Pittsburgh and from other places across the state about the importance of vaccines. The last thing I'll say is I've worked with respiratory viruses for nearly 25 years. You guess from my accent that I'm not from Pittsburgh. One of the first viruses I worked with, human viruses, is measles virus. And whenever I worked where I'm from in Ireland with measles virus, a virus for which we have a wonderful vaccine, there was an unsubstantiated link between measles vaccination and autism. And what happened was the use of that highly efficacious viral vaccine decreased. Because measles is such an infectious virus, as larger numbers of small children who had not been vaccinated because of this unsubstantiated link between measles and autism, as they grew in numbers in the population, because a case of measles anywhere in the world is a case of measles in our part of the world, and in that instance it was Ireland. We had a big outbreak in Dublin, over 1,000 children infected with a vaccine preventable virus, and 3 children died. And that really impacted my research thinking. It taught me that undermining these wonderful vaccines by scaring people because you provide not scientifically sound information, but invalid, unsubstantiated links, can really have an effect on real people in real places, on real parents with real children. And that's why this conversation, to my mind, is so important. It was important 20 years ago in Ireland when we had this big outbreak of measles, and it's absolutely critical in this pandemic. So that's just a little bit about me, where I'm from, what I do, where I'm based, and I look forward to our conversation this evening. Thank you, Brad.
Thank you, Dr. Dupre. And I would like to introduce our third panelist for this evening. We have Dr. Obinna Nnedu, an infectious diseases physician from the Ochsner Health Foundation in New Orleans, Louisiana.
Thank you so much. And I just want to thank the Carnegie Science Center for inviting me. I am always very, very excited and thrilled to speak at forums like this, to speak about the COVID vaccines, to answer questions that people have. A little bit about my background. I am an infectious disease physician, meaning that my training is in the treatment and prevention of communicable diseases like COVID and other types of infectious processes. I'm in New Orleans. I'm not in Pittsburgh with you all. Just a little bit more about myself. I spent most of my life in the Southeast, outside of some short stints in Nigeria, where my family is from, and in Seattle, Washington, as part of my training. Most of my life has been spent in Alabama and in Louisiana. in terms of training and now in terms of working. I'm very, very familiar with a lot of the hesitancy that's out there in terms of the vaccines, and I hope to be able to speak to that and answer many of those questions. I hope to be able to speak a little bit about the vaccine trials. I served on a committee that was made up of African-American scientists and policy experts, and we essentially provided, we were an advisory committee to the Coronavirus Prevention Network, which was coordinating the 5 of the COVID-19 vaccine trials in the US. And so as part of that work, we were able to give some ideas, give some perspective, and specifically ideas and perspective, from the Black and African American community. I can say that there were advisory committees also made up of Indigenous and Native Americans, as well as Hispanic Americans. And I bring that up because these groups historically have had challenges with access to healthcare, challenges that in many ways are structural and historic. And as the COVID pandemic really raged, these groups were really heavily hit. And so it was important for me to be part of that advisory group to provide some advice as far as the vaccine trials were concerned. And it's important to me also to be a part of forums like this to be able to speak and answer questions. My job is mainly in training young physicians, training young infectious disease physicians. I serve as the program director for the infectious disease training program here at Ochsner. And we really had a time in terms of COVID. And I work in the hospital and I teach, and that's what I do every day that I come to work. And I always tell people that I've never, at least in my career, seen something as dynamic as COVID, as something disrupts society, at least here in New Orleans, here in the U.S. In my lifetime, the way that COVID did. In New Orleans, many of you are familiar with Mardi Gras. We had our Mardi Gras celebrations towards the end of February last year. Not knowing too much about COVID, we had millions of people come down to New Orleans and have a good time. And I would advise those of you here listening, post-pandemic, when things come back to normal, please come down to New Orleans and enjoy our city. But we had a lot of people come here during Mardi Gras, and about 2 weeks later, we completely got overrun and completely got slammed. And I saw a lot of people pass away. Patients who I had taken care of for years passed away. I saw a lot of families dealing with trauma from losing loved ones. And so for me, again, talking about the vaccines is so important and it's so personal to me. And I hope I'm able to answer your questions. Please ask questions. And I look forward to being with you guys for the next hour or so. Thank you.
Thank you very much, Dr. Nnedu. At this time, I would like to ask all of our panelists to turn on their cameras and microphones, and we will get started with some of the questions that we received in advance. All right. So we had several questions asked in advance when people registered for the program. We're going to focus on those to lead our discussion to start. We may have other questions that come up during the course of the discussion. I know at least some of you have found the Q&A button in the bottom of your Zoom window. Feel free to enter any additional questions that may arise during tonight's conversation, and we'll try to get to as many of them as possible. But to start out, I would like to use some of the questions we received in advance. So this question is for any of the panelists, but I think it might be directed to Dr. Dupre first. is, a very basic question of how the COVID vaccine works and how it may be different from other vaccines like the measles vaccine that you had mentioned before. And I'm assuming that the questioner is referring to the mRNA vaccine technology, but you can interpret that how you like.
Okay, so it's a great question, and it's exactly where we should start. A little bit of science. Whenever I said about Jonas Salk and Sabin, who made the poliovirus vaccines, really only had a couple of options. They could chemically inactivate the virus, or they could genetically change the virus so that instead of causing the disease, it was weakened, and the term that we use is attenuated, and that attenuated vaccine looked like poliovirus, but didn't cause the disease. And the key thing to bear in mind whenever we're working with vaccines is what we want to do is train the body into knowing what the virus looks like in the wild, so to speak, before the human meets real virus. So how vaccines work is we change the virus, we attenuate it, we weaken it, or we make a vaccine which contains a little bit of the virus. Now, it would be nice if we had slides to show you the virus, but you've seen this on television. Just imagine that virus with all of those sticky out bits. Those are the spike proteins. And those are the proteins on the outside of the virus that the immune system recognizes. What does the immune system have? The immune system has antibodies, makes antibodies. And these antibodies latch on to the virus and they take out or neutralize the virus because they're very specific to attack that virus whenever you meet it, on the bus or walking down the street or whatever. So your body's ready to go. So that's the first really important thing whenever we're talking about vaccines, just remembering or remembering or learning how they work. We put something into your body which looks like the virus, that doesn't cause the disease, that trains your body to be ready for the real live virus whenever you meet it. Now, that allows me to answer the question, how do they work? Salk could really only have dreamed about the many ways we have to generate new vaccines. And in fact, what's really interesting about the COVID vaccines is we have two very different approaches that were pushed through rapidly, tested in exactly the way we normally test vaccines, but two completely different ways to train your body into knowing what SARS virus looks like, SARS-2 looks like. The first is messenger RNA or mRNA. Messenger RNA is a genetic material, and the genetic material is the material which is used to produce the spike proteins that stick out of the viruses. So instead of using a factory to make these proteins, these sticky out bits on the virus, you actually use the body's normal machinery, which makes proteins all the time, proteins that make my cells in my skin, and proteins which make neurons in my brain, and proteins which make things in my eye, proteins in my cones and rods and all this stuff in my eye. You use the body to make the viral protein. And then that viral protein, that spike protein, is seen by the immune system, and the immune system learns what it looks like. A fundamentally different way to make a vaccine. And now we have to talk about the companies that push those forward. That's the Pfizer vaccine and the which was produced with BioNTech, and the Mrna vaccine. So if you've had either of those two vaccines, you've had a messenger RNA vaccine, and you've been a little factory, you've made the proteins yourself. The other vaccines that you could have been received is the Johnson vaccine. And again, it's a very different way to make a vaccine. What the Johnson vaccine does is it uses another virus, and that virus is called an adenovirus. And that adenoviruses cause the common cold, and they're very common viruses. You can grow them really well. But what you can do with these adenoviruses is you can put additional genetic material into the adenoviruses. So you can make a mixed up virus which has adenovirus on the outside and the spike protein, not in the form of RNA, but in the form of DNA inside that little adenovirus. And in exactly the same way as you getting a measles shot, you get jabbed with the adenovirus. And in a single shot, that's the difference between the adenoviruses in Johnson & Johnson's vaccine and the mRNA vaccines with Moderna and Pfizer. They take 2 shots. The adenovirus, just a single shot, but the same process happens in your body. The adenovirus brings the genetic material in. The genetic material is DNA. DNA gets changed to RNA. Again, very similar to the Moderna vaccines. The RNA gets changed to a protein. Those proteins are those spiky proteins, and in your body, the body recognizes the spike proteins, it makes antibodies, and it's ready to fight SARS-2 if you make it in the wild. Hopefully that explains how they work. It's rather technical, but it's really very novel and very different. But the principle of vaccination is the same. Train the body, get it ready to fight, so that whenever the virus comes along, it's able to take the virus out.
Okay. If any of our other panelists have anything you'd like to add for this particular question, feel free to chime in now. Otherwise, we can get into some of the more advanced questions for the evening. Okay, so building on that question about how the vaccine works, we have more than a couple of people asking about how the vaccines are tested. Specifically, for the mRNA vaccines, how do we know that they're safe? How do we know about? How much do we know about any long-term effects that can be expected, whether those are side effects or whether that's long-term effectiveness of the vaccines? Dr. Nnedu, you mentioned that you worked on some advisory committees with the vaccine trials. Maybe you can share some of your experience for this question.
Thank you. That's an excellent question. And I think that in terms of, some of the questions that I've gotten, including this question, stem from maybe how quickly the vaccines were developed, as Dr. Dupre alluded to. I just want to say that mRNA technology has been around for some time in terms of studies, in terms of use in humans. I also want to sort of allude to the fact that based on how our immune system works, how our immune system responds to things, and how our immune system responds to vaccines, we generally don't expect any side effects related to vaccines to appear beyond 2 months out from getting the vaccine. That's generally the case. I think I just want to add a little bit to what Dr. Dupre mentioned. With these mRNA vaccines, when a person is vaccinated, the actual mRNA material's half-life, so how long it actually stays in the body or in the cells, is relatively short. The body, the body's immune system sees it, the proteins, what it needs to process from it are processed, and then it quickly gets rid of it. So it doesn't stay in the body and it doesn't alter the body's DNA. What you really are left with is a protein, an immune response. The immune response promptly gets rid of the protein, and what you're left with is memory, immune memory. Your immune system now remembers, but the actual protein and the mRNA itself doesn't stay in your body. You're left with memory. And so I just wanted to sort of point that out, that those things don't stay in the body. I also want to point out that we are starting to get more information. Obviously, the clinical trials happened. We had some initial data that came out that looked at up to 2 weeks after getting your second dose as far as the mRNA vaccines in terms of safety and efficacy. We have started getting 6-month data that's still showing that it's safe and that it still maintains efficacy. We'll keep getting more data as far as that. But I think so far, not just in terms of America's experience, but other countries like Israel that have published some of their experience in terms of real world vaccine use for the mRNA vaccines, we're still seeing safety, and we're still seeing that it's been effective.
Great. You mentioned that we typically expect to see any vaccine side effects manifest within 2 months. And we had another question here asking if that traditional 2-month expectation holds, true for the newer mRNA vaccines. Is there any reason to suspect that is different for the newer vaccine technologies compared to the older technologies?
No, there's no reason. Again, sort of based on how the vaccines work, you as Dr. Dupre very nicely discussed, you introduced mRNA vaccine into the body. Something that looks like the coat of the coronavirus is produced. The mRNA is completely destroyed and is gone. And then that protein coat is recognized, the immune system gets rid of it, and then the immune system remembers it. And so it's the different format, but the basic principle is the same for the other vaccines as well. You're introducing something into the body sees it, recognizes it, gets rid of it, and then there's a memory that's ultimately built to that.
Great, thank you for clearing that up. We have several questions about some specific side effects that people have noticed. First one of those questions, this is for any of our panelists, is there are a number of women noting differences to their menstrual cycles after getting one of the vaccines. Is this something that is concerning, or how widespread is this? What sort of light can we shed on that question?
I'll take a stab at this. So this is a report, these are reports that we've seen in the lay press saying that there are some anecdotal reports of women having differences in their menstrual periods. But what I would say is that there's no conclusive evidence that this is actually linked to the vaccine, or that this is actually anything but kind of what we would call a spurious association, something that happens after the vaccine, but is not caused by the vaccine. And you're going to have to get used to a lot of that type of reporting, because what we're doing is trying to capture as much data as possible to give people to really understand the safety of these vaccines. So anything that can get reported is reported, but not all of it actually ends up being substantial. I can't think of a biological mechanism for how a vaccine like this might cause that type of side effect. I think that this is something that we'll study. We'll look to see if there actually is a signal. But I know there's been a lot of rumors about fertility in this vaccine. It's important to remember that women got pregnant during the Pfizer and Mrna vaccine trials, that this doesn't have an impact on fertility. And I fear that people are bringing up this menstrual irregularity to try and associate that with some impact on fertility, which doesn't exist. So I would say there's not anything to worry about with this right now. I think that there's not enough data to be able to say anything conclusive about it. but I don't think that this is something that's a real causal link. It might just be something that's happening after the vaccine, not because of the vaccine. And that's a critical thing that we have to emphasize to the public, that not everything that happens after the vaccine is caused because of the vaccine. Things just happen, and just happen to have had a vaccine prior to that.
Okay. So there's a similar question here. This is from someone who developed severe tinnitus after receiving their second dose of the Pfizer vaccine, and it's been continuing 12 weeks later. And there's another question, saying people are reporting, tinnitus, hearing loss, trigeminal and vagus nerve inflammation after receiving the COVID-19 vaccines. Has there been any sort of link established in those types of effects?
Yeah, so just to kind of speak to that, I think Dr. Adalja really kind of addressed that, some of these things very, very nicely. The clinical trials, there were thousands of people that were enrolled, and all side effects are documented and are investigated, and by nature reported to the monitoring entities. So specifically, this was not specifically seen as far as the trials as being clearly linked with the mRNA vaccines. Now, one of the things that Dr. Adalja also alluded to is that we're really being robust with the rollout of these vaccines in terms of monitoring all side effects, everything that's reported, and so forth. And so one has to be a little bit careful. One has to just be mindful that there are millions and millions of people who've gotten the vaccines at this point. And so, I think if maybe a few people or a handful of people say they had X, Y, Z, it doesn't necessarily mean that it's the vaccine causing it. That's one thing. The second thing is, one will concede that everyone is a little bit different. Some people do react a little bit differently, but that's certainly not a reason to not take the vaccine. And I'll just point out that actually getting COVID has been associated with a lot of neurological problems, far more significant than whatever numbers of people might be reporting tinnitus. Actually getting COVID, I've seen long-term effects from COVID, neurological effects. I've seen cardiac long-term effects that can only be linked to COVID. And so these things are far more common if you actually get COVID. And so there's tremendous benefit to getting the vaccine, to protecting yourself from COVID. And even if you're from a group that is not at very high risk, you invariably have loved ones or people around you who may be from a high risk group. And protecting yourself from COVID would also be keeping them safe. I got my vaccine for me because I wanted to be safe, because I see patients who are vulnerable. I wanted to keep them safe because I live at home with people who are vulnerable, and I wanted to keep them safe.
Okay, thank you very much.
I think this is one thing we have to be aware of. People often say these vaccines were developed very quickly. These vaccines we don't know so much about because they are new ways of making vaccines, giving vaccines. Yes, the vaccines are quite new, but you also have to remember, so is this virus. And we don't know a lot about SARS coronavirus 2. We don't know very much about the long-term effects of that virus. And as you've just heard, they are not insignificant. So whenever people say this is a really new vaccine, I'm not sure about this is a different way of giving it. That's true, but remember, this has gone through a tried and tested, rigorous way of preclinical, that's before you put a vaccine into people, testing in animals, and then clinical testing, stage 1, stage 2, stage 3. Then it gets emergency use, and then all of these reports after this emergency use get collected, and people look for patterns in not just tens of thousands of people, hundreds of thousands of people, but millions of people. So it's really important that we look for these patterns, but it's also really important to remember that the virus is new and we don't know what the long-term consequences of this virus are. And we're already learning that long COVID is a thing, that people who used to ride bikes, climb, used to run, are totally debilitated after having been infected with coronavirus, SARS-2. So we just have to get a balance there. And what people typically say about vaccines is, and this is measles and mumps, yes, there are reactions to vaccines, right? Your arm will be sore, but that's your body doing the normal thing, raising this memory immune response that you've heard. It's just the normal stuff. So yes, you get a vaccine, you get a shot, something happens in your body, that's good. But you get a virus that we don't know very much about, and something certainly happens in your body, and some people get very sick. And as we know, many people in our country have died because of it. And we don't know what the long-term consequences are. So you really have to think about those two things side by side. Very important.
So there's another question here about the long-term effects of COVID-19 and what sort of research or improved treatments might be helpful for some of these patients, or we can think of that as are there any improvements in the way we're treating long-term COVID on the horizon that maybe in your positions and could talk a little bit about that are not common knowledge with the general public?
I'll take a quick stab at this. So I think early on, I think right now we're just sort of scratching the surface when it comes to long-term COVID. We know that it occurs. We don't have a good idea of who's going to get it. We know that people who are severely ill that end up in an ICU are not going to jump right back to their normal baseline. That happens with any type of severe pneumonia. But what we're finding is that there are some people who have mild illness that end up having the inability to go back to their activities of daily living. And I think the key thing here with long haul COVID is first to come up with the definition so that we can actually study it. Because right now there's a lot of different people that have a lot of different symptoms and they're kind of getting grouped together. We've got to refine that first to be able to study it and come up with treatment. And what we'll likely find is that there is a subset that have the inability to do what Dr. Dupre just said, go back to climbing, go back to walking upstairs, go back to their activities of daily living. What we know so far is that they seem to be older, they seem to have more medical problems, and they seem to be female. That seems to be the only trends that we've seen right now. Multiple medical centers all around the country are now setting up these post-COVID clinics in order to study these individuals. There hasn't been any real major treatment advance yet because I think we're just, like I said, in the infancy. Some of these patients, for example, may have difficulty regulating their blood pressure when they stand up. There's a syndrome, if you're interested in, called POTS, P-O-T-S, that some of these people may have, and they get better with just compression stockings. So there's still just a lot of science that needs to be done and a lot of clinical trial work to understand what happens here. But this is definitely a real phenomenon. This is one of the reasons why you don't want to get COVID, even if you're a young, healthy person, because you might be one of that rare group that ends up with long haul COVID. And we know that the vaccine is something that will prevent you from having that consequence. So I don't know if Dr. Nnedu has anything to add with his experience with these patients.
No, I think you nailed it right on the head. I think it's still new. We're still trying to define what a case is. I suspect I suspect that definition will be fairly broad. I think a lot of people have a lot of different symptoms. And in terms of therapies and treatments, right now, I think we're still in the early phases of learning, understanding, and hopefully something will be developed to help our patients. But I would like to just add that I think that's another really strong argument for vaccines. Even in the cases where you have breakthrough COVID infections in people who've been vaccinated, those tend to be much milder. People tend to not get that sick, and as such don't tend to have much of the long sort of consequences. And so, please consider vaccination. There was some information that the CDC just came out with amongst the people who've been vaccinated up till April the 30th. I think the infection rates were something like 0.01% or something along those lines, incredibly low. And then when you look at severe illness and actual death and hospitalization, even more minuscule. And so the vaccines really help to protect you. And even in that, rare instance where you might have a breakthrough infection, it tends to be milder.
Great, thank you very much. So I'd like to change course slightly here and talk about children. We have several questions here from parents wondering about the vaccines that are out there for COVID-19 and children. And so the first question is, do you have any idea when the vaccine will be available to children under age 12?
So this is something that's ongoing right now. There are clinical trials going on with both the Pfizer and Moderna vaccines. They're figuring out the dosage, they're figuring out the side effect profile in this group. And I think this is an important thing because we just don't reflexively give the vaccine to every age group. Every time you give someone a vaccine, you have to go through what's called a risk-benefit calculation. You look at the risk of the vaccine, and you look at the risk of the disease, and you look at the benefit of the vaccine. And that's different for different age groups. So you want to study this deliberately. So it's very different when you're vaccinating a 6-year-old versus vaccinating a 60-year-old because their risk for severe disease, their risk for spreading the infection are very different. That's why these trials are going on. The best estimate I've seen is probably around Thanksgiving is where we're going to get the next emergency approval for another age group. Hopefully that goes faster, but I think it's something that's going to happen eventually. And I think it's important that we go through these deliberate steps just to prove the safety in this age group where there are different risks and different benefits that may occur.
Okay. And so we have a lot of people who say that COVID-19 has less of an effect on children as it does adults, and especially adults with high risk conditions. So we have a question here: is how should a parent adequately assess the risk of vaccinating their child against COVID against possible unknown long-term effects? And I think this goes back to some of the questions we answered before already about long-term effects of the vaccines. But how would you counsel a patient asking about vaccinating their children?
That's a great question. I would just, as I answer that, I'll just couch it and say that I practice adult medicine, so I don't frequently counsel, parents in terms of the vaccine. I would just say that yes, the data shows that children are less likely to get severe illness. I would also say yes, we're still learning in terms of what COVID might mean in children. There was a sprinkling of cases of children that got COVID that had some severe complications that sort of made the news. And so we're still learning. And I think that, and so I think from my standpoint, it's a slightly bigger unknown in terms of what happens to a child long-term who gets COVID, and then what subset of children might be at risk for having severe COVID if they get it. Whereas I think that the vaccine, as Dr. Adalja alluded to, is going through trials right now in children. We'll get that information. I also suspect, as he does, that we'll get information suggesting that it is safe, but we'll wait to get that information. And once that information comes out, I think we'll feel more confident in terms of making those recommendations.
Again, I think that's a really good take-home message for folks who are listening. This isn't being done fast. It's being done really carefully, really deliberately. It's being dialed in the right direction to get the right dose in those correct age groups. It's just, we can't take any risks with vaccine development and vaccine testing, because vaccines are way too important. It's not just about coronavirus vaccines. The many vaccines that our children already get, we do not want to undermine the public's confidence in those vaccines by pushing something forward fast, by doing something which would be overly risky, by not understanding really carefully what's happening during the, again, preclinical and clinical testing of these vaccines. So kids get a lot of vaccines already, and a lot of the vaccines that they get have been, or all the vaccines that they get have been tested in exactly the same way as the coronavirus vaccine will be tested, or is being tested at the moment. And I would like to believe, and I would like to hope that as people listen to this conversation, they would see that as reassuring. Remember that vaccination is a social contract, right? This is what's hard sometimes to think about with vaccines. Yes, you do it for yourself. But as Dr. Nedu described, he does it not for just himself, but he does it for his close connections and his patients. So therefore, all that we can do as a community to reduce the replication of that virus, this rapid replication of that virus in many people, all that we can do to reduce that decreases the likelihood that people who have yet to be vaccinated will get it. And again, we haven't talked about it yet, but we should. It reduces the likelihood that these variants arise, which then become the next problem and the next problem and the next problem. So that social contract of reducing the virus replicating is good for us all. Another argument for children being vaccinated.
Excellent comments here. And, following up with what Dr. Dupre says here about, this is a social contract. This is an effort for the community. Can any of the panelists here shine some light on how many people in the community need to be vaccinated to actually have that protection built in for everyone who either can't get the vaccine or hasn't yet been vaccinated? I know we hear several numbers going around here in Pennsylvania. The number 70% of adults being fully vaccinated means that we'll be able to take and put away our masks in public, for example. But what's that critical mass of people that need to be vaccinated to have this ultimate effect of stemming the spread of COVID?
So this is a concept of herd immunity. And this is a little bit of a controversial subject because we don't quite know the number, and we don't know if that's actually what the be-all, end-all would be. And it's a simple mathematical formula to understand what that number should be. So the more contagious a virus is, the higher the population level immunity needs to be. So for COVID-19, we think it's probably in the 70% plus range, especially with more highly contagious variants like the Alpha variant, or which used to be called the UK variant, or the Delta variant. Those things are more contagious. So that requires a higher herd immunity. But I've been someone that says herd immunity is an important goal to strive for, but it's not the be all and end all. Because remember what I said earlier, we're not trying to drive COVID-19 to zero. It's not going to go the way of smallpox or even polio. This is going to be something that is going to become a respiratory virus that we deal with day in and day out. And when you look at countries that got highly vaccinated, like Israel, they saw a precipitous decline in cases when they got to about 40% fully vaccinated. We're over that in the United States. So I think the goal really has been to deny the virus the ability to cause serious disease, hospitalization, and death. And I think we get there even before you hit that herd immunity threshold. And it's also important to remember that when you think about herd immunity, it assumes that this is going to get a little technical, the population is all the same, that everybody has the same risk of getting the infection or spreading the infection. And that's not true. So when you look at states like Texas and Florida, which did a lot better than we thought they would, that might be because their spreaders, the younger people, got infected and got immunity from natural infection, which then decreased the spread of the virus. So this is a complicated thing to remember, to think about, And we also, just one more thing on herd immunity, is that it's not just vaccination, it's also prior immunity that people have that also plays a role that makes it harder for the virus to spread. So I don't, even though the number might be something that's very high, I think we will still progress positively in this pandemic just by getting the vaccination number as high as possible, especially when we have 75% of those above the age of 65 fully vaccinated in this country. And that's kind of what we wanted the vaccine to do, was to tame the virus and make it more like other respiratory viruses.
Great. So since the theme of this evening is community health, we need to recognize that our communities are not all the same. Our communities are not homogenous. We've got various ethnic, racial, social groups that make up our communities. And one question that we have here is that why should people of color trust the vaccine? And I think that might go very nicely with the advisory committee that Dr. Nnedu served on. But let's talk about that for a bit, shall we?
Yeah, no, I think that's a fantastic question. I think that there's a lot of historical reasons why people of color may be a little bit distrustful of healthcare. Not just dealing with the Tuskegee experiments and so forth, but a lot of other things, really dark chapters in our history. And even in present day, in terms of access to healthcare, we know that it's different, amongst different groups. And so, I definitely think that that's a great question. I think I'll answer it in a couple of ways. One, I would say that there are a number of checks and balances and rules that have been put in place in terms of trials to ensure that people are not exploited, people are fully informed when these clinical trials are going on, but also to increase the diversity of the people that are included in these trials. I can say that Pfizer, Moderna, Johnson & Johnson, they certainly made an effort to include people of color in those clinical trials. That was a big part of what the advisory panels were involved with, was trying to ensure that that people from underrepresented groups, from groups that have been historically marginalized, are included in the trials. It gives us a lot more confidence that these vaccines will work in sort of real world situations. And so I want to say that. And then the second thing, and I sort of alluded to it when I initially spoke, we know that there was a disproportionate impact of COVID-19 itself, not just in terms of hospitalizations, in terms of deaths. The people from underserved communities, particularly the Indigenous American community, the Hispanic community, and the Black communities, were hit significantly hard. Not just from a health standpoint, but from an economic standpoint as well, in terms of jobs lost, income lost, and so forth. And so, for me, I really think it's incredibly important that communities of color really consider getting the vaccines, and really ask these questions and ask whatever questions that you have about the vaccines at forums like this. And I always try to be available to speak in these forums, because I really do think that it's important that communities of color really consider strongly getting vaccinated. in order to, and really everyone in America should certainly consider getting vaccinated. The more, as Dr. Adalja alluded to, the more of us we get vaccinated, the more protected we'll be as a community to COVID, and just the overall safer our society will be.
Great. And oh, I'm sorry, I think I had an echo here. So what other resources might a curious person have available to them? Obviously, you can talk to your personal physician, but what other resources do people have to ask those questions and learn about safety records of the COVID vaccines and mRNA technology in general? Where can people learn more about these topics?
I think there are a number of resources. I think the CDC has a lot of has a lot of resources that are geared towards people who don't have a medical or scientific background, that are certainly understandable. Certainly, if people in the audience have a medical or scientific background, they can look at other resources at CDC. I know that the Coronavirus Prevention Network, COVPN, if you just Google that and look up resources, they have resources tailored towards different communities, some in Spanish as well, and that kind of give information in terms of the vaccines.
I also worked on a project with the Ad Council, and there is a website called getvaccineanswers.org where you can get a lot of information there as well. So that's a non-CDC website, but it is something that's also got a lot of information there and encourages people to ask questions and gives straight answers to all of them.
Also, I think the professional societies, I'm a member of the American Society for Virology and the American Society for Microbiology, and they do a lot of really great public outreach. For example, they've had town halls allowing people very similar to this to ask questions about the vaccines and really bring experts to the fore, because again, what you heard in our last question was whenever people have the questions about vaccines, they really want trusted messengers. They want to be talked to by people who are credible. And that's the challenge whenever we use the internet as a source which we rate equivalently. Not all web pages are equal, and one click and another click and another click and another click, 4 clicks, can get you into very, very bad places in the internet. And that's where people need to be careful. And I just love that we started with the CDC. This is what the CDC is for. This is what these trusted messengers are for. And this is also what organizations like Carnegie Science Center is for. We're local, we don't feel as remote, or you don't feel as remote as the CDC. You are physically in Pittsburgh. So not only do these big national organizations have a role and responsibility, not only do the professional societies have a responsibility, but we have a responsibility because we have our spheres. Tonight we have a sphere in the Carnegie Science Center, but we also have our own personal spheres. We go to play soccer, we play volleyball, we go to church. All of these interactions that we have allow us to interact and champion the vaccines that we know work. So I think it's everybody plays a part in communicating why vaccines are important.
Thank you all very much for those great resources and thoughtful answers. I would like to switch over to a few of the questions that were asked by the audience who's watching here this evening. So we have one question here, which I think came up very early in the evening, is do you think artificial intelligence might be used to help predict when the next health crisis will occur? Any thoughts on that? Maybe Dr. Adalja.
So I think this is kind of one of the cutting edges in trying to understand how new infectious disease emergence will occur. And we're sort of seeing a melding of biology with computer science. And I think that it's very hard to predict what will happen, but we've got so much data out there now, so much to mine, so much that so many things to look for signals. And I do think that this is only going to make it much better when it comes to predicting infectious disease emergence. I think that you're going to see this kind of emanate out of the government, out of the federal government, World Health Organization, as well as big research centers, and eventually we'll get down to the local health department level. But I do think that this is what we're trying to move towards, to have much more ability to predict the way an infectious disease will spread, where hotspots might be, kind of collating many different sources of data and putting it all together. So I do think we have a chance now in the wake of this pandemic to get much more aggressive and proactive when it comes to preventing the next infectious disease emergency that we're surely going to face. And I think Dr. Dupre probably has something to say about that too.
We know that pathogens emerge. This is history. We get in this, the word unprecedented has been used. We get in this unprecedented moment, a snapshot of what has happened across millennia. As pathogens jump into new populations that don't have any natural immunity, no memory immunity. And we know that this has caused a tremendous amount of human suffering across the globe. We just look at India, the tragedy in that part of the world. It's not just an American problem. It's not just a problem in Ireland, in Europe. It's a global problem, and this is going to happen again and again. And if we think about the money that we have had to spend developing vaccines reactively as opposed to proactively. SARS-1 came along, burnt itself out, no vaccine. MERS, Middle East respiratory coronavirus, came, infected camels, is still circulating a little bit, but didn't come to the rest of the world. So therefore it's not a problem. No vaccine, no human coronavirus vaccine brought to market. Third time, SARS-2, we knew that coronaviruses could emerge. We knew that they came from animals. We knew that they could spread. We knew that they could cause significant human suffering. Look what happened because we didn't spend the money on basic research, spend the money understanding SARS-1, MERS, which were giving us an opportunity to be ready for the big one, and the big one happens to be SARS-2. So I just love the idea, whoever asked that question is really bang on the money. We can do things, we can look for patterns using artificial intelligence, we can join things up in ways that we could never have done before. Biology surprises us. Biology is super complicated, it's not binary. It's gray. These guys who treat patients will tell you that that's what patients are. It's why the doctor, the physician interaction with the patient is so important, because you don't do the same thing for everyone. But by looking for patterns, by funding basic research, think of the money that we could have saved if we had brought a coronavirus vaccine to market. So I say, let's learn. I say, let's take all of these bright minds, these wonderfully creative young people who know not just biology and not just vaccines and not just antibodies and not just medicine, but who know how to program, how to code, how to think about interactions between computational biology and bioinformatics and biology and all this stuff. And let's use these people and let's give them that challenge to get us prepared. Because the words you're going to hear often in the future are pandemic preparedness. We're watching for flu. We're thinking about avian influenza, right? And bang, here comes the coronavirus. We're watching for coronaviruses. We forget about avian influenza, and bang, here comes Ebola virus from another animal reservoir because of climate change and a spread of a vector like a mosquito or a tick or something like this. The world is super connected. And that's where artificial intelligence, I think, is going to be incredibly interesting, what it does, how it helps us with our small minds think big.
I like the way you phrased that. Helps our small minds think big. That's fantastic. So we've got a few minutes left, and I certainly will give each of the panelists a moment to make some closing remarks if they so choose. But I would like to get in one or two more of our questions. One theme that came up many times tonight is that COVID's going to be with us for the long term. This isn't something that we're going to be eradicating. It's something that we're going to be living with. So people, I have several questions here about how we might go about the vaccine process with COVID in the future. Do we think this is going to be a virus that will require us to get booster shots? Do we think there might be a different shot every year, like we have with the flu virus, with all of the new COVID variants that come up? Are we going to see a different shot formulated for types of COVID that are circulating? What do we have to look forward to for prevention if we don't currently know all the long-term treatment possibilities?
Yeah, that's a great question, and I would just say that we at the moment we're the individuals that were enrolled in the phase 3 clinical trials are still being followed. So we don't know for sure exactly how long the vaccines remain effective and what we want them to do, which is to prevent death, prevent severe illness, most importantly, and then also to prevent any infections. I alluded to the fact that Pfizer and Moderna have some information about 6 months, and they still seem to be relatively effective. I think Johnson & Johnson should come out with its 6-month data soon if it hasn't already. And so I think we're going to learn in terms of how long. We're also going to learn how effective the vaccines are to some of the variants. Again, the benchmark being, prevention of death and prevention of hospitalization being sort of the two really key important things. And then other key things such as preventing disease and preventing transmission will also be there. And certainly the vaccines still seem to, reduce the risk of death and reduce the risk of severe COVID, even against some of the variants that we're seeing here. And so we're going to get more information as time goes on. I don't think we can say with 100% certainty if boosters will be needed and the frequency with which boosters will be needed.
Thank you for the reminder. I would like to get into just a little bit more about the mRNA, because this is what we've had a lot of questions about. Aside from the new mRNA vaccines that we've seen, what other mRNA therapies have been used in humans? Cancer treatment or any other uses? And what might we have learned from those other mRNA treatments that can be used to know more about the long-term effectiveness of the vaccines that use mRNA?
I would just say that, so with mRNA vaccines, it's important to remember that companies like Moderna weren't necessarily founded to work on infectious disease. They were looking at use of mRNA vaccines as tumor vaccines for cancer. And that's where they've worked on them for decades. That's where we get that safety profile from the mRNA work that had been done with cancer research. although there has been nothing ever approved yet, nothing had gotten this far in clinical trials, we had a lot of human data, a lot of animal data based on what companies like Moderna, what BioNTech were doing with mRNA for other applications. There was an influenza vaccine approach that was being done with mRNA vaccine. And just to recommend, if anybody listens to the New York Times Daily podcast, the one from today is all about mRNA vaccines. So I think that there was a lot of interest in mRNA. And I think we're probably at the cusp of a very exciting time, probably a revolution, not just in vaccinology by using mRNA vaccine technology, but also in therapeutics and vaccines for non-infectious diseases like cancer. So I think that this is a really exciting time. And I think the mRNA story is just beginning to be written, and it's going to be very, very exciting.
Yeah, I just want to say, I mean, that's absolutely correct. And I think I think over time, scientists have learned how to store the mRNA vaccines stably in a way that now we understand how to store it, how to transport it. And as Dr. Adalja alluded to, we have built up some safety information. And I also agree. I think mRNA vaccines are going to be exciting. There are folks who are looking at it in terms of HIV, as well as other illnesses. And so I think it's exciting. I think it opens up a whole new door, a whole new method of delivering things. Just as Dr. Dupre mentioned, vaccines do, essentially the same thing. You introduce it to the body sees something that looks like the disease, responds, and then there's a memory so that the body can respond quickly anytime you're exposed to it. And now we have a new tool that is exciting, and I think there's going to be a lot of research into it.
Perfect. The last question I will get into is looks to be pretty technical. This person wants to know more about the lipid nanoparticle used in vaccines and wondering if that's a new technology and what we know about the safety of lipid nanoparticles as they might be used in vaccines.
So yeah, it's pretty technical, and that we don't need to go into the minutiae of the technicalities of that, but simply whenever you hear that word lipid nanoparticle, that's essentially like an artificial virus, okay? Viruses are nanoscale lipidated, so lipids just means fatty. So essentially what a virus is bad news, the genetic material in this lipid coat. The genetic material on the inside, the lipid on the outside, and what the viruses do is they are perfectly tuned, evolutionarily tuned to get into cells and infect us. What we try to do is we try to copy nature, and that's basically what a lipidated nanoparticle is. We're copying what a virus is, and we're retuning that very small piece of, a very small particle to carry a cargo that isn't the genetic material of a virus, but it is the genetic material of something that we want to deliver. There's a lot of work has been done over many years, as you just heard. Mrna didn't just come from nowhere whenever SARS coronavirus came along. A lot of studies have been done looking at the reactogenicity of these particles, because that's how the RNAs are brought into the cells. You've heard already that the RNAs are not that stable. Once you get injected with Moderna or Pfizer, very quickly the RNAs are degraded after they make the proteins. And that's why you have to protect them in these lipidated nanoparticles so that you can get them into the cells, so that the cells can do the work, so that you can be the vaccine protein producer, and then you can make a good immune response. So a lot of the knowledge has come from studies on, for example, cancer therapeutics with Moderna. And again, it's the same as anything that's in a vaccine. It has to be tested. It has to be tested in animals first. And there's a lot of data out there saying that these are good ways to get genetic material into cells. But of course, we always need to keep an eye on it, right? We shouldn't just No scientist will ever say, oh, that's done, we don't need to worry about it anymore. Scientists are nosy and inquisitive. They always look at data, and we constantly want to look at what we have and reassess it. Can we make it better? Can we move it forward? Can we do it in a different way? So again, science is self-correcting. It's always checking. I think people need to be aware of how science works, and that we don't want to just say, oh, it worked. Let's not keep an eye on it. We keep an eye on vaccines after they're licensed, and we keep an eye on many different components of vaccine after it's been licensed.
Great.
We just don't stick things into people willy-nilly. Vaccines are too important to do that. And again, that should give people the confidence of what's happening, what's being developed, and the rigor that we need to go through in vaccine development and testing and licensure.
Great. And Dr. Adalja, you had something to add.
I was just going to say that we use lipid nanoparticles for other medications. There are common antifungal medications that have lipid nanoparticles. So this isn't unprecedented to use a lipid nanoparticle.
Great. Good information. Thank you to our panelists so much for joining us this evening. I would like to give each of you a minute or two to share any last remarks that you might have. I'll just go in the order that I see you on my screen. So Dr. Nnedu, we can start with you if there's anything you'd like to end on.
Well, I just want to say thank you guys again for having me. And to the audience, I hope we were able to answer your questions. Please be inquisitive and please consider getting the vaccines. It'll protect you. It'll protect those that you care about, that you love, and it'll keep your community safe. Thank you.
Thank you very much. Dr. Adalja, anything you'd like to end on?
So again, thank you for this opportunity. I hope that we were able to answer questions and hopefully nudge people who might have been on the fence towards getting a vaccine. I would just say that this vaccine is something that allows you to get your life back. It makes you no longer a threat to others, and it makes others no longer a threat to you. It is a way to actually, it gives you personal individual value to get this vaccine. And I think this is something that people should really get. And also, just remember, we're going to face more infectious disease threats. It's really important to advocate that we are prepared for infectious disease threats in the future. This isn't the last time you're going to hear from me, I'm sure.
And we'll definitely call on you for the next health threat that starts making waves here. You can count on that. And Dr. Dupre, is there anything you'd like to close on?
Probably after clean water, vaccines have done more for human health than any other intervention. Antibiotics, I'm sure, could give vaccines a good run for their money, but two incredibly important ways to treat infectious disease. One, before you meet the disease, and one when you have the disease. These molecules that we make are so vital for human health. And we should value both. We should value human ingenuity, human creativity. Humans are intrinsically creative organisms. I think what we have learned over the last year and a half is, in response to this global pandemic, how wonderfully creative humanity can be. Ready to respond, virologists, epidemiologists, immunologists, clinicians, people who work in industry, people who understand nanoparticles, people who understand delivery, people who understand manufacture, people who understand logistics, right? It's not one person. It's humanity being creative, applying that creativity to solve a problem. That is encouraging. But remember, we can be as creative as possible. We can dream different ways to make vaccines. But it's not a real vaccine until it's taken in a real syringe and injected into a real arm. We can do all of this but vaccines should be used. And I would just encourage the folks who are listening to champion them, understand them, ask questions about them, but also use them, because vaccines work.
Thank you very much. On that note, I would like to again thank all of our panelists for joining us this evening. We appreciate you sharing your time with our audience here. And for everyone at home watching, I do invite you to join us for our third and final panel discussion coming up on July 1st. Our theme will be What's Next for Public Health, and we have Dr. Deborah Bogan, the Director of Allegheny County Health Department, Dr. Ariangela Kozak, Research Fellow at University of Michigan. We have Allison Beam, the Acting Secretary of Health for the Commonwealth of Pennsylvania. And we have Dr. Anuradha Ray, Professor of Immunology at University of Pittsburgh. Thank you again, and I hope to see everyone here joining us for the third panel discussion. Have a wonderful evening, everybody. Thank you for joining us.